everyone, good evening. Today we will discuss about cystic fibrosis. So what is the mode of inheritance in cystic fibrosis? It is autosomal recessive. The gene involved in cystic fibrosis is CF gene, that is cystic fibrosis gene, which is present in the chromosome number 7q. Okay, and the protein responsible for this is being CFTR, that is our cystic fibrosis transmembrane conductance regulator. I'll write it here. This protein is cystic fibrosis transmembrane conductance regulator. That is the protein that is responsible for this wholesome disease called as cystic fibrosis. This cystic fibrosis is a multi-system disease. Why it is a multi-system disease? Why? Because this CF gene or this protein is being expressed. That is being expressed in their epithelial cells. They are being expressed in the epithelial cells of your airways. They are being expressed in the GI tract. Third, in your sweat glands. Next, in your pancreatic duct or the pancreas. In your genitourinary tract. So these are the places where your CFTR gene or CFTR protein has been expressed. So this is a multi-system disease. It is affecting every parts of your body. Okay, so the inheritance, coming to the recap. So the inheritance is by autosomal recessive way. The chromosome involved here is a 7q. This is the chromosome involved. There are around 1400 mutations. So among the 1400 mutations, the most common or the most prevalent. So the most prevalent mutation. So the most prevalent mutation is deletion of phenylalanine. It is deletion of the single phenylalanine. This is an amino acid, right? So deletion of single phenylalanine residue at your amino acid number 508 region. Okay, so there is a deletion of this single phenylalanine at 508 region is the most prevalent or the most common mutations. That is F508 deletion. Okay, next, going on to the types of mutation. We have classification of mutation. So classification of mutation is mainly based on their severity of their presentation also. Okay. So classification of mutation, we have 6 types or 6 classification. We will bring it down here. Okay, I'll explain. So going to the classification of mutation, among them we have 6: type 1, type 2, type 3, type 4, type 5 and type 6. So you have to remember is there won't be any functional capacity of this CFTR protein in these 3. First 3, there is no functional capacity of CFTR protein. While in type 4, 5 and 6, there will be a presence of CFTR in a small quantity. There can be a presence of CFTR protein in small quantity. So they will be presenting with a milder symptom compared to the person having this class 1, class 2 and class 3 mutations. So what is the effect? What is the mutation or what is the effect on CFTR protein? First, in type 1, there is a lack of protein production. So there is a lack of protein production that is leading to absence of this CFTR protein, right? Next, in type 2, there will be a CFTR trafficking defect. So there is a CFTR protein trafficking defect that will cause retention of this misfolded or the protein that is not being formed properly. So that is leading to retention of this misfolded protein. In type 3, it is defective channel regulation. There is a defect in their channel regulation, so that your CFTR protein is not being expressed on your epithelial cell surfaces. In type 4, there is a reduced or a decrease in the channel conductance, but you will have the CFTR protein in a small amount. Fifth, there is a decrease or reduced synthesis. There is no total absence, but there is a reduced synthesis of your CFTR protein. In type 6, there is a decreased stability, but CFTR protein is being expressed, but there is a decreased ability of your CFTR protein. So this is the classification of mutation. First, among the classification of mutation, the first 3 will not have any functional capacity of your CFTR protein, while the next 3 will have some quantity of CFTR protein being expressed. Next, we will see the pathogenesis in their sweat glands. So first, in their sweat glands, it is different in the sweat glands and also in the respiratory pathway. So in sweat glands, it is mainly acting in the chloride channel. Okay, so this is your sweat gland. Here mainly it is acting, it is mainly acting in your chloride channel, the CFTR protein. Okay, so normally this is lumen and this is your interstitial surface. Normally the chlorine and the sodium will come from the lumen into your interstitium. So when that is happening, all your sodium chloride will be absorbed into your skin, so that your skin is not being dry, or your saltiness or skin frosting is not being seen. While in cystic fibrosis patient, your chloride channel will be defective. Since your chloride channel is being defective, none of your chloride is going into your interstitium. It is everything is being present. This chloride is everything being present in the lumen. Since your negative charge is being in the lumen, it attracts your positive charge, that is your sodium. So sodium is also being attracted and being stored in the lumen itself, so that the child will present with salty skin or skin frosting will be present in the child. So all of your sodium chloride and water being lost through your sweat, so that the child can present with what? It is hypochloremic metabolic alkalosis. Since there is a due to a loss of your more amount of sweat is being getting lost through your lumen, so the child can present with hypochloremic metabolic alkalosis, especially in the summer situation, summer time. Okay, next, what is happening in your respiratory tract? In respiratory tract, here again you have lumen and you have this cells. This is epithelial cells that is lining in your airway lumen, and here you have your interstitial fluid. So normally we have CFTR channel here, that is being mainly acting in your chloride channel. Okay, CFTR protein is mainly acting in your chloride channel. Normally your chlorine will go out from your interstitial fluid into the mucus, and your sodium and water will get absorbed from the mucus in a normal amount. Okay, in a normal amount, your sodium will go your chloride will go out, and sodium and water is being absorbed in return for the loss of your chloride. So in cystic fibrosis airway, what is happening? There is defective in the CFTR. Since there is a defective in the CFTR, your chlorine is not going out. Since your chlorine is staying inside your interstitial fluid, to balance your chloride ions inside the interstitial fluid, your sodium and your water is being pulled more into the interstitium. Since your sodium and water is being pulled more into the interstitium, your mucus will be, that is the mucus that is lining the airway lumen, will be dehydrated. Why? Because more of your water and sodium is being pulled inside, so there will be a dehydrated mucus. Since it is a dehydrated mucus, there is no effective mucociliary clearance. Since there is no effective mucociliary clearance, there will be bacterial overgrowth. There is a stasis of your mucus that is serving as a site for your bacterial overgrowth. So that can lead to your bacterial overgrowth and inflammation, and this cycle repeats. Okay, so this is the pathogenesis behind your cystic fibrosis in your sweat gland and also in your respiratory tract. Okay, next, so this pathogenesis, what will it lead to? So what is a pathological lesion in the lungs? So the pathological lesion First, initially it will affect the small airways, then only it will go on to your large airways. Since the small airways are being affected first, there will be bronchitis. That is inflammation. This is inflammation of the small airways, or small bronchioles. Okay. Next, sorry, I'm wrong here. Since there is inflammation of small airways, there will be what is called bronchiolitis. Next, this inflammation will extend into the large airways. What is it called then? It is bronchitis. So this bronchitis on a long standing duration, what is it leading to? It is called as bronchiectasis. Okay. Next, this is happening in the lungs. What is happening in your nose? That is in the nasal mucosa. So in nasal mucosa, the child will experience, or the child will get a multiple polyps, a large or a multiple polyps. These polyps are mainly from their axillary and ethmoid sinus. Okay, these are the pathological lesion in their lung. Next, next we will see the clinical features. So what is happening in your intestinal tract? First, in your intestinal tract, your meconium, your peristaltic movement will be delayed, so your meconium will not be pushed outside. So the child can present with a meconium ileus. So the child will present with meconium ileus. So what are the features in meconium ileus? The child will have an abdominal distension with delayed passage of meconium. Next, the child will have emesis also, that is vomiting. The child can also present with emesis. The child will have abdominal distension with delayed passage of meconium and emesis. On taking X-ray, this X-ray, you will see the ground glass appearance can be seen. This ground glass appearance is due to your meconium. Ground glass appearance plus all your large intestine, mainly your large intestine will be blocked with this meconium, so that you will see this ground glass appearance. So since your large intestine is being blocked, or it is being constricted, your small bowel, your small intestine, you will have a air fluid level in your small intestine. Fine. This meconium ileus can also lead to meconium peritonitis. Meconium peritonitis meaning your intestine has been perforated or penetrated. It is in your intestinal perforation has happened. Your meconium is being spread towards your peritoneum. So that is leading to meconium peritonitis. Meconium peritonitis, suppose if it is happening in the fetus, that is in utero, what will be your antenatal scan finding? In antenatal scan, you will see peritoneal calcification or scrotal calcification. So you can see peritoneal or scrotal calcification if suppose the child or the fetus have a meconium peritonitis. Okay. In older children, they can present with features of constipation, failure to thrive, that is SAM child. Okay, they will be presenting it as severe acute malnutrition. Plus they can also have the features of distal intestinal obstruction syndrome. So distal intestinal obstruction syndrome, that is the way they can present, as with the constipation, with a large distended abdomen, with the absent bowel movement and all, bowel sound. Okay, when you take a contrast enema, you can appreciate a microcolon. Okay, so these are the features in your GI tract. Second, what are the features in your pancreas? In pancreas, first, your exocrine secretion is being affected. So secretion of this pancreatic juice is not expelled into duodenum. Since it is not, because the pancreatic juice or pancreatic secretion is mainly responsible for your fat and protein absorption. Since your fat and protein are not being absorbed, you can see the child can pass a stool which is very bulky stool, foul smelling. It's a foul smelling bulky stool. It is called as steatorrhea. Next, since there is no absorption of fat, that will lead to malabsorption of fat soluble vitamin. So that will lead to malabsorption of your fat soluble vitamins like A, D, E and K. So you have to extra supplement these vitamins. Fine. Next, in biliary tract. In biliary tract, the child, since your biliary tract will also be blocked, so the child can present with prolonged jaundice or neonatal jaundice. Okay. Next. In pancreas, it is mainly an exocrine insufficiency in the beginning. The child can present with endocrine insufficiency. That is, when there is an endocrine insufficiency, what will happen? There will be a decrease in your insulin. So the child can present with the features of diabetes mellitus at around in the second or in the third decade. So the child will present with features of diabetes mellitus in your second decade. Okay. So these are the features of the child with cystic fibrosis in your GI tract. Next, in your genitourinary tract. In genitourinary tract, what will happen? Third, genitourinary tract. In genitourinary tract, there will be a congenital absence of your vas deferens or obliteration of vas deferens. So there can be a congenital absence or obliteration of vas deferens. This can be bilateral. So that will lead to absence or failure of development of Wolffian duct. So there is a failure of development of Wolffian duct. So that is leading on to infertility in male, and in female they can present with reduced fertility. So these are the genitourinary findings. So we have seen sweat gland, respiratory tract. What will happen because of the dehydrated mucus, which is long standing there, impaired mucociliary clearance, there will be a repeated or recurrent respiratory tract infections will be present. We have seen respiratory tract, GI tract, genitourinary tract, and in the sweat glands. And how we are going to diagnose the child with diagnosis of a child with cystic fibrosis? First is your sweat chloride test. Okay, it is the most specific and sensitive test for your diagnosing cystic fibrosis. So sweat chloride test, once you can collect sweat chloride from the forearm of a child by normally you can collect, or by giving a pilocarpine ionophorosis you can give, and you can collect the sweat. So to collect the to test the sweat that you have collected, your collected sweat should weigh at least 100 mg. Okay, so your collected sweat should weigh at least more than 100 milligram. Okay, next, in this, when will you consider it as positive? So it is considered as positive when the child have a sweat chloride of more than 60 milli equivalents per liter in 2 separate occasions or 2 separate days. Then you call this test to be positive. Next, we have another term called as borderline. Okay, so when you will call as borderline, when the level is between 30 to 59 milli equivalents per liter, it is called as borderline. Next, we have negative. When will you say your sweat chloride is negative? When it is less than 30 milli equivalents per liter, then it is sweat chloride test is negative. Whom all you can test? You can test in all the children. Supposing if you are suspecting this cystic fibrosis in the newborn period, you can test the sweat chloride test for a child who is more than 35 weeks of gestation more than 36 week of gestation, and the child should weigh more than 2 kg, and the day of life should be at least 10. Okay, the child should be at the 10th day of life. So it should be more than 10 days or more than 2 kg and more than 36 week of gestation to test your sweat chloride if it is in a newborn period, if you suspect cystic fibrosis in a newborn period. Next, what are the causes of false positive sweat chloride test? So what are the causes of false positive sweat chloride test? So why we are discussing this in very detail is, you suppose if you get a bronchiectasis case in your practical exam, if you go into cystic fibrosis, they can ask all such questions. Okay, so this is useful for your practical also. Okay, so false positive sweat chloride will be present when the child is having malnutrition. Second, in eczema, that is atopic dermatitis. Okay, third, in epidermolysis bullosa. Fourth, when the child have hypothyroidism. Fifth, in child with the congenital adrenal hyperplasia or in child with adrenal insufficiency. So these are the situations in which you can have a false positive sweat chloride test. Next, so after supposing if you do sweat chloride test on 2 separate occasions and you find the child to have a borderline is between 30 to 59 milliequivalents per liter, what is the next investigation you will do? So next choice of investigation will be your nasal potential difference. Next choice will be your nasal potential difference. Okay, so in this nasal potential difference, there will be a, in patients with cystic fibrosis, there will be a increase in this potential difference. So potential difference between what and how we are going to test? So this potential difference is between, there is an increased response to your amiloride application. When you apply amiloride, there will be an increased response, but there will be an absent or a decreased response to the beta adrenergic agonist. There will be an absent or a reduced response. So that you tell the child is having an increased potential difference. Okay, so this is the second test. Next, third one is to test your pancreatic function. So to test your pancreatic function, you will do a quantification of elastase 1 activity in the stool. It is a 24-hour collected stool. Okay, you have to do a quantification of elastase 1 activity in the 24-hour collected stool. Okay, next, for newborn screening, you have another method for the newborn screening. So what is the method for newborn screening is, it is called as immunoreactive trypsinogen. It is immunoreactive trypsinogen test. And you can also use DNA analysis. Okay, DNA testing on your dried blood spot. DNA analysis on your dried blood spot, but it is a limited DNA analysis because you cannot analyze every mutation, that is around 1400 mutation. Everything you can't analyze, you can analyze only a limited set of mutations. This is about the testing that you will do in a child with cystic fibrosis. Next, what is the diagnostic criteria? So we have diagnostic criteria for cystic fibrosis that will include presence of typical features. So the recurrent respiratory tract infection, or the child with steatorrhea with failure to thrive, or the child had a history of delayed passage of meconium. So these features. So when the child have a typical features of the cystic fibrosis, or with a history of cystic fibrosis in the sibling, so everything will be or when the child have a positive newborn screen. Newborn screen is your immunoreactive trypsinogen is being positive. So you are having a positive newborn screen. Next, so in among these three, any one plus plus your lab diagnosis. In lab diagnosis you have 2 elevated sweat chloride level. So 2 elevated sweat chloride level on 2 separate days. Or where the child has, this is all, okay, or if the child has 2 cystic fibrosis mutation, or the child is having an abnormal potential difference, nasal potential difference. So this is the diagnostic criteria to tell that the child is having a cystic fibrosis disease. Okay, next, what will be your treatment? So first we'll go from the diet. So you have to give a high calorie diet to this child. Next, secondly, you have to supplement vitamins. So what is the level of vitamin that you are going to supplement? So mainly you have to supplement A, D, E and K. So I am telling mainly for the age group between 1 to 5 years. So 1 to 5 years you will supplement vitamin A level of 5000 international units, vitamin D of around 500 international units, or it can be between ranges actually it is 400 to 800. To remember, I am telling it as 5500. Vitamin A is around 50 international units, and K you will give a weekly dose. Weekly once you will give an IM injection of vitamin K of around 0.5 mg. Okay, so this way you can remember the dose you are going to supplement. Second, other vitamins, other water soluble vitamins should be given as twice their RDA. Should be given as twice the RDA should be given. And you can supplement extra salt during the summer. Extra salt can be added to the child. Even in salt also you have to add extra potassium also. Potassium chloride, you can give it as potassium chloride syrup. Okay, you can add potassium at the dose of 2 to 3 millimole per kg per day. So you have to supplement with minerals, that is you can have to add extra salt during the summer month, plus you have to give KCl also additionally. So in that potassium level should be around 2 to 3 millimole per kg per day. Okay, so this is about your diet. Another one, diet, and you have to, because your pancreatic enzyme is being deficient, so you have to supplement with pancreatic enzyme replacement. So pancreatic enzyme replacement is by providing the child with the tablet lipase. Okay, so how will you supplement? What is the dose? It is around 3000 to 5000 international units per kg per day. Okay, this one you can divide it as 1000 international units per kg for your main meal, and for 500 international. So whenever the child is eating, you have to supplement the child with your lipase. Okay, that is pancreatic enzyme. This is for your snack, not main meal. This is for your snack. 500 international units per kg for your snack. Maximum dose of this pancreatic enzyme will be 10,000 international units per kg per day. Okay, that will be your maximum dose. Okay, next, while supplementing this lipase, you have to keep it inside the food. You have to crush that. It will be like a granules. You have to crush that, or you can keep it inside the food. Why? Because this can cause glossitis. It can cause intestinal strictures. It can cause ulcer that can lead to your intestinal stricture also. Fine. Next, how will you increase the dose? What will be your what are you going to assess after giving lipase? You have to ask the mother whether the child is passing a bulky, foul smelling stool the child is passing, or how many times the child is passing stools. If the child was passing like around 5 to 8 times per day, now the child is passing around 1 to 2 times per day of normal stool, it is a good improvement. Okay, next, so we have finished about the diet. Next, main thing will be your respiratory. In respiratory, what you have to do? Mainly it is an airway clearance. You have to clear the airway, because mainly it is a dehydrated mucus that will get clogged, or it will get stasis in your small bronchioles. So you have to clear the airway. So you have to do airway clearance therapy is the main. How you can do? One, by your postural drainage. Postural drainage is by So whichever this thing is affected, whichever your lobe is affected, you have to do a postural drainage according to that. If your lower lobe or your if your middle lobe or your upper lobe is being affected, you have to make the child to lie down in the cot, and you have to bring a head down position. You have to bring a head down position, and you have to do a percussion. That is, you have to do a chest physiotherapy. Next, this can be carried out by also using your autogenic drainage. So autogenic drainage is only for your older children. So what is autogenic drainage? It is a controlled breathing technique. So you're teaching the child a controlled breathing technique to expel this your mucus. Fine. Next, you can use your other mechanical devices. So other devices that is mainly having an oscillatory positive expiratory pressure. So which is having an oscillatory positive expiratory pressure. So what are the devices that is having this? These are aerobica and acapella. So these are the two devices that is having this positive expiratory pressure devices. Okay, so these are the ways you can do a airway clearance. Next, you can do by giving a inhalation therapy. So in inhalation therapy, we have first one, we have your human recombinant DNAs. Actually, this human recombinant DNAs will dissolve. This will dissolve your DNA that is present in the neutrophils. So once the DNA that is present in the neutrophils are being dissolved, your neutrophils will die. So once the neutrophils die, your viscosity of the mucus will decrease. So that way you can easily expel the mucus out. So it is given as a single dose, and it will improve your pulmonary function, and it can decrease the exacerbation of the cystic fibrosis. Okay. Next, second, you can use hypertonic saline. This hypertonic saline can be, we normally use 3% saline, but you can also use 7% saline for the patients with cystic fibrosis. Okay, you have a method to do this chest physiotherapy to a child. First, you have to start giving a salbutamol, that is bronchodilator. First, you have to give a bronchodilator to the child. Next, you have to give hypertonic saline inhalation. You can give it, this is through a nebulization process. Okay, this is given through your neb. Next, after around 20 to 30 minutes, you have to do a chest physiotherapy. So this is the way how we are going to clear the mucus secretions or thick mucus that is present in the lungs. Okay, this should be repeated at least 2 to 3 times per day. Fine. Next, we have other inhalation therapy. You can have antibiotic inhalation therapy like tobramycin. Okay. Next, we have another one specific antibiotic, that is your macrolide, mainly that is your azithromycin. This is being used as a immunomodulator drug in a cystic fibrosis child. So this has been considered as a immune modulator in cystic fibrosis. Okay. Next, actually this decreases the sputum's viscoelasticity. So the azithromycin will decrease the sputum viscoelasticity, and it will decrease the airway adhesion of your pseudomonas also. So it will decrease your airway adhesion of your pseudomonas. This is given at the dose of 5 mg per kg per day. Okay. Suppose if the child has respiratory symptoms or signs or change in the lung function with the chest x-ray findings and all, and you have admitted the child. If you have admitted the child, what are the organism you will suspect? The most common organism will be your Staph aureus. In older children, your most common organism will be your Pseudomonas. the organism that is having increased risk to death will be your Burkholderia cepaceae. Okay, so these are the organisms that can cause a that can lead to bronchiectasis in this child. So mainly for these children who has been admitted in your ward with the findings in the chest X-ray or low lung function, you have to give if it is admitted in the ward, you have to give an IV antibiotic therapy for a duration of around 14 days. You have to give that too. You have to give mainly a 2-drug therapy if you suspect Pseudomonas. If you suspect both Pseudomonas and Staph aureus, then you have to add over 3-drug therapy. Pseudomonas with Staph aureus. Okay, the doses of these of your antibiotic drug should be a maximum dose for these children. Suppose if you are suspecting only a mild infection, you can treat it in a home-based management. Then you can give a oral antibiotics for a duration of around 2 weeks. Okay, same 14 days only. Okay. Next we have final. We have CFTR modulators that can modulate your gene or your CFTR protein. So what are the CFTR modulators? First one here is your ivacaftor. Second is your lumicaftor. Third one is your tisacaftor. This ivacaftor is FDA approved and it is given in the age group of more than or equal to 12 months. Lumicaftor is more than or equal to 2 years and tisacaftor for more than or equal to 12 years old. Okay. So this is about your cystic fibrosis. I hope you have understood the management, diagnosis and the pathogenesis involved in this. Thank you. We can all learn pediatric together. Please like, share and subscribe my YouTube channel. Thank you.